for joining us. Hope you get really amazing value out of this. And what we are doing today is I am speaking to a good friend actually from university. We go way back when. And we have a really good time. We had a really good time together in university. And then Tamara, who is a physiotherapist, she's and she'll introduce herself as well, but she's basically specialized in orthopedics and pelvic floor. And Bev is joining us. Hi, Bev. Nice to see you. And what's really cool about that combination of specialties in physio is that it's a little bit like in medicine, I kind of think about it like family medicine and then specializing. So you get like when you go in, and correct me if I'm wrong, Tamara, but when you're a physiotherapist, you get like a basic kind of training. And then for you to actually be able to really, really dive deep into something as complicated as the pelvic floor, which can be complicated for people who don't understand it, right?
Yeah.
Then they can, you have to do extra training, and you have your own business that you work at Mondays, Wednesdays, and Thursdays from your home, which you're at right now. It looks lovely there in the background. And then you work with another business on Tuesdays and Fridays. So, and so today what we're talking about is your pelvic floor, and I love it. You sent me like a list of myths. And I was looking at it, I was like, oh, those are myths? I thought those were real.
Yeah.
Right. And the ones that we chose to focus on today was and then we'll see if time permitting, because we can go until 8:30 is or 9:30 is correct me if I'm wrong, is the myth that painful periods are a part of PMS. Right. Yeah. And then you mentioned that there was a connection between that and leakage, because that's something that women, so painful periods with PMS and leakage is, I've been hearing that in the Facebook group. And so, if you could let us know, like give us your wisdom. I want to know.
Yeah. So, hi everyone, I'm Tamara. I have been doing pelvic health for almost 11 years now, and also been a physio for 15. I, started out in the whole sport world and worked with high-level teams and athletes, and did my training in Australia. So I was very blessed to have some phenomenal mentorship there, and worked in neuro as well at GF Strong when I came back, and BC Women's and stuff. And, I found that unfortunately our system is so behind and not preventative, very medical oriented, no offense, but and I think my perspective in terms of physiotherapy and rehab and pelvic health and even orthopedic stuff with respect to sport injuries and stuff is that prevention is key, essentially, and transfer of knowledge. So really getting education out there so people can take control and take responsibility for their health, and then move forward with that and ask questions and be comfortable asking questions, because a lot of people are faced with this. Well, the doctor said that's normal. So for example, the leakage. Oh, well, after you have babies, it's normal to leak. So, a lot of the time I'll be talking to women, I'll be like, so do you leak at all? And they're like, no. And I'm like, no, kind of, yes, maybe sometimes, right? And all of it is technically not normal. You should not be leaking, right? And so, oh, well, sometimes when I cough and sneeze, well, that's still technically not something that we want to have happen. It's not good for your system to be, leaking when you cough or sneeze, right? So, and the same idea revolves around your period. So this is my big beef that I'm hoping to try to change a little bit, is that, young people are not taught about their reproductive health early on. They're taught about, sex, and this is what sex is. And but the idea of what is a normal period? Is there such thing? No, it varies for people, but painful periods are not normal. And so if that can be addressed through learning about your reproductive health and understanding how to support it, like the stuff that you, I'm sure, talk about. And then, understanding what your pelvic floor is and what it does, because, there are, lots of things that it does, right? It's a supportive, it's a sexual, it comes into the sexual sort of perspective and intimacy. It's a part of your core. So for those kids that are really high level athletes early on, or kids that don't meet all developmental you know, things that can be potentially issues down the line. And then the whole constipation thing when you're young, or even as you age, or even with periods, can also compromise your pelvic floor, right? So I think it's kind of, everybody kind of is sort of uncertain of what is actually normal, and is there a normal, right? And I would say that there's a variability of normal. I would say, you know, your pelvic floor is not going to be the same as mine, which is not going to be the same as the, you know, a 5-year-old child that I see, which is, you know, and then the men that I see, like I have a professional motocross athlete I'm treating right now, and he has some pelvic floor symptoms. And it's fantastic that, you know, because within my practice, people know what I do, they refer people on, and that's what should be happening. Oh, look, actually that might be related to this. So I want you to work with this physio, and we can collaborate. And that's the big thing, is collaboration with different, within professions, but also with other professions, to kind of facilitate an improved like transfer of knowledge and support and care for even prevention, right?
Totally. And it's very topical. Like even Natalie, who's watching this, and she made a comment just now, she said she had their last baby 4 years ago and she still has all of this. Right. And so,
yeah. Well, I mean, that is a very common person that walks through my door, and they're like, oh, well, you know, I'm a lost cause. It's, you know, been 4 years and there's no way to rehab it. But there's huge gains and recovery as well, from 4 years ago, right? So I think it's important to know that no matter where you are in your journey of postpartum, or, you know, even not postpartum, you don't have to have had a child to have pelvic floor issues. So that's another myth, right?
Yes.
You know, your pelvic floor issues can be from not having children, or they can be from having children as well. And so I think knowing that there's always a support and potential resolution for it is really important. Go ahead.
Oh, yeah. So I was just kind of wanting to understand, like, so say someone like this walks through your door, like, can you walk us through, like, what are some of the common, like, reasons? Like, I don't know if there's like one major thing that you always see, or is there like some categories of things that you see? And then like, how would you initiate that approach for treatment?
So if we're looking at more specifically the postpartum woman, you're looking at women coming through the door with painful sex, decreased libido, inability to reach orgasm, painful periods, prolapse, cystocele, rectocele, leakage, urge, like increased urgency, frequency, diastasis rectus abdominis, so which can play a role in the pelvic floor health. And I'm trying to think of what else, some painful pelvic pain conditions as well.
Yeah. So the diastasis is when the abdominal wall kind of opens, so you notice it when you're kind of lying down, it bulges out. I have that actually, which I'm working on, but yeah, okay.
Yeah.
And like, sorry.
Go ahead.
Oh, and is that like, is that from like the trauma of the child coming through the canal? And like, typically, like, I'm trying to understand. So in the old days, like, was it that woman before, when they would have childbirth, they would like end up their lives having this, like before all of this, you know, when women were bearing, like in the wilderness, they were bearing their children, they were giving birth. I'm assuming that it was like a process that was self-healing, you know, you would give your birth and then there would be some things that would happen and you would heal. And now we're seeing that there's a lot of women who are giving birth, and for whatever reason, are they not healing, or was that always the case and now we're able to treat it? Like, what's your sense of what's going on? Like, why are we seeing this now?
Well, it wasn't talked about.
Wasn't talked about.
And realistically, most women that I see in their 60s and 70s and even their 80s, like, this is not a topic of conversation. They're like, I wish my friends and I knew early on, you know, that there was something that we could come and do after having babies, right? And it's not a topic of conversation. So, you know, these are women who have had this conversation and been able to, you know, be referred on to me or to pelvic health. But it's not a common thing that is spoken about in that demographic and that age group. And then it's cultural as well. So there's different cultures that, you know, the pelvic health side of things, and even like, you know, birthing and all that is not spoken about. It just happens, it's done, and then it's done, right? And then I think changing demographics with respect to, like, you know, intercultural marriages, like, so, you know, my husband's 6'4", 200, big-headed German. Like, I couldn't get my babies out. They were huge, and their heads were 90th percentile. So I had 4 cesarean sections. Now, that doesn't, again, cesarean sections do not mean that you have the easy way out. You still have pelvic floor issues with that, and commonly one of them is pain with intercourse after having cesareans. So, you know, there's that whole assumption as well that if you go the route of a cesarean, you're going to just bypass all these issues. Well, it's not true, right? And then, of course, you know, historically, you know, the evolution of women, speaking with respect to, you know, the workforce, like, we are tending to do more now as mothers, potentially. Like, there's a lot more women in the workforce compared to back in the day. And, you know, and I don't mean that being a stay-at-home mom is not working. It definitely is. I just mean with respect to stress levels and capacity. And then also a lot of women are, you know, getting into, you know, athletics and training, and all that is shifting and changing as we evolve, right? And that's normal. So I think a lot of things play into that whole concept of why is it becoming more of an issue now? And I think it's always been an issue. It's just that it's never been addressed. And most people don't know what their pelvic floor is, right?
Yeah. So yeah, like, let's take a step back and, like, what when you speak of pelvic floor, what are you speaking about? And I'm sure you're pulling out a model or something.
Yes. Well, this is the pelvic. So this is your pelvic floor. So this is obviously with everything stripped away, right? So this would be like in sitting or standing. Your pelvis is this way. This is the posterior. Okay.
Okay.
So this is the undercarriage. All right.
Oh yeah,
so
yeah.
You've got your pubic bone. You've got your clitoris, your urethra, your vaginal opening, and your anus. Now, of course, it would be different for a male, and I don't have a male one here, but I usually pull up images. I just don't treat men as often, right? And so then if you take away these ligaments here, so basically you have more of a superficial region of the pelvic floor, okay? There's 4 layers, and each layer goes deeper and deeper, okay? And this is the deepest layer, all right?
Oh, okay.
So the only way you can reach that superficial layer externally, just by external palpation. But as you do an internal exam, your second, third, and fourth layers, you can only reach internally.
Oh.
These guys, along with your piriformis, okay? So piriformis, obturator internus, they all connect with the hip. That's why the hip is a huge part of assessment with respect to pelvic floor as well.
Right, the hip bone, right? Yeah.
The femoral head, right? And then, of course, you've got this huge levator plate, right? And this is the area that needs to relax to get the baby out, okay? And it's the area that you need the lift, the support from too, right? So these guys in the second layer are the more layers for that whole continence. I mean, they all work together like a domino effect, so you can't really say they work separately, but then you've got the puborectalis, and these are the areas that tend to get torn, right?
Oh, so more the superficial layer, not the deep layer where the baby's coming through? That can too?
Okay. Grade. So your grade 1, 2, 3, 4 tears, right? And then the oasis stuff, which is the anal sphincter tearing, that's going to be your higher grade because it goes all the way through. Even in depth, it goes all the way through, right?
Okay. Yeah.
Where it varies, and it has to be assessed because a lot of women end up with internal tearing and they don't know.
I was just going to ask that because there's the obvious tearing that the doctor says I had to stitch you up and whatever, but then there's what you're saying is that there's internal tearing that could be not detected, and that could be leading to problems. So how do you detect it? Do you detect it through the manual palpation, or is there certain exercises, or do you use an ultrasound?
Well, I use ultrasound, so real-time ultrasound, as well as, but as a pelvic health physiotherapist, we're not allowed to be diagnostic in our ultrasound techniques. So I use it more as biofeedback, but because I've been using it for like 9 years and doing internal exams at the same time, I can help people understand what is going on, especially if they're not keen on that internal exam, because you do not have to have an internal exam every time you come for pelvic floor physio. It's completely up to the patient, right? And that is not my place to make that decision for them. So but that said, yes, to determine that internal tearing, so a levator hiatus tear or something, a tear in the levator ani muscle, so the deeper muscle, then you do need an internal exam to kind of determine what kind of role it's playing in maybe their symptoms, for example, prolapse, because they're very common with prolapse.
Prolapse being the internal organs which are normally held up by these muscles like a sling. The muscles no longer can act like a hammock, so the internal organs are starting to come down, and that, I guess, can lead to some of the pain with intercourse and the peeing when you don't want to, and the constipation too. Is that how the constipation links in?
It can also be obviously hormonal, but it also can be related to, and I'm going to talk a little bit about this, that high tone pelvic floor. So the tonal pelvic floor, right? So you can have tearing being an issue because of the adhesions or scar tissue. But when you do have internal tearing, so if you look at, this is the situation of the bladder, the uterus, and the rectum, okay? So you have an anterior vaginal wall and a posterior vaginal wall, okay? So just to determine the difference between prolapse, cystocele, and rectocele, okay? So the prolapsed uterus is this guy, so your uterus.
The white guy.
It's falling down the vaginal cavity. So your cervix, which is in here, falls into the vaginal cavity. So that's a prolapse. Then you've got your cystocele, which is the anterior vaginal wall weakening, right?
Oh, okay.
And the bladder goes, ooh, I'm going to pocket in there, okay?
Oh.
You see that more of a bulge at the opening. And then you have the posterior vaginal wall, and that can cause a rectocele. So the celes are different than prolapses. And so the rectocele is the one where you get the bulging posteriorly. Now that would come with symptoms more of constipation and that kind of stuff. Your inability to feel like you empty properly. There's a lot of things that can co-occur though. So you can have a prolapse of the uterus with a cystocele and rectocele, right? And then there's also the urethrocoele. So the little urethra can have little pocketing because of, some drag when the baby comes out too.
Wow. Yeah. So I guess like a new onset constipation after childbirth would be more indicative of constipation being structural. It can still be hormonal, as you say, because postpartum you have all these hormonal things, and sometimes we don't recover from it fully if we're not intentional about it. But that's extremely fascinating. And so when you do your internal exam, can you differentiate between the three different things? Oh wow. Okay, that's very cool. And
they can also come, like, so if you're looking at any athletes, like especially with the surgeon in weightlifting and stuff like that, and CrossFit, sometimes and gymnasts and stuff, sometimes these things can occur, like I said,
just
without
from exercise.
Bearing. Yes. Now that's not obviously, or from straining because of having a significant history of constipation. So it's not just to say that they occur in postpartum, but what can happen is then that woman goes on and has a baby, and then maybe they become symptomatic as well.
Right. Okay. That's very interesting.
So you can have that. So people's history is really important, of course, right?
Right. So you would take a history, do a really good physical exam. Absolutely. And so you've done that. And what are some, just to give us an idea, like, because it's interesting, right? Some of it is muscular integrity. And I could imagine if you do certain exercises, which I'm going to ask you more about, you can fix that. But for like a rectocele or a cystocele where it's a thinning of the wall, are there things you can do to reverse that or compensate?
Well, there is. I mean, obviously your nutritional health and, hormonal support is really important, because sometimes it can be, especially in the population that's like, menopausal, postmenopausal, you're looking at, estrogen and progesterone balance and all that kind of stuff, right? Which can help and assist improvement in that tissue. the other aspect is also your pressure system. So your whole body plays on your pelvic floor.
Mm.
You've got your nervous system, your dural system, you've got your core, your pressure system, so your breath, your diaphragm. So for example, let's just take, a doctor who does a lot of work over patients, or, you've had a couple kids, you are quite rigid and tight through your thorax. Well, that puts more pressure. And let's just say also you work out quite a bit, you run, you lift weights. That can put a lot of pressure on your diaphragm and create an imbalance of pressure with your pelvic floor. Depending on what your strength and your strategy is for connecting to that deep system when you're exercising, lifting, moving, whatever, right? So that balance of that core is also really important. So for example, diastasis, if there is a diastasis, it's important to determine, is it functional? And then if you can generate that tension, then that's great, because then you need to load the system to improve the, increase the strength and connectivity and support essentially for the whole body.
So sorry, go ahead.
Yeah, but what happens is that it creates pressure sometimes. Let's say the pelvic floor is not happy with that situation, and your pelvic floor, you have a mild cystocele. Well, pressure is really important to that, because if you can offload some of the pressure and change the strategy a bit, then sometimes you can change the grade of cystocele or the symptom of that cystocele, for example.
Got it. Okay. So it's like offloading the root cause.
Yeah.
Right. So it's root cause physiotherapy.
Yeah. As opposed to like, oh, you have this in your pelvic floor, let's just get you
focus on the pelvic
use
floor.
Your Kegels, because that's actually not the be all and end all ever.
Okay,
right?
that's a really good thing. I think that's a myth, right? That if you do your Kegels, you're going to do your pelvic floor. And another myth, I think, is that if you're a strong person, like you mentioned, CrossFit and lifting weights, you can be very like appendicular strength, like arms, and maybe even your chest looks good and your thighs or whatever. But you mentioned that there's these very specific core floor muscles. And so I'm just going to put a place mark there, because I want to know what are some examples of exercises that you do for these deeper core that's not Kegels. And I'm going to bring you a question from the audience. Natalie's asking a question: can pelvic floor issues cause frequent urination? It's been getting increasingly worse since having kids and freaking me out a little, which is why I haven't had it looked at. And then she puts a smiley face. So
yes,
good question, Natalie.
Absolutely. And you can actually have urgency, frequency, not because your pelvic floor is weak or damaged per se, but because you have high tone in your pelvic floor, for example.
Okay.
So your pelvic floor is a dial. It's not an on and off switch. It's a dial like your core, because it's a postural muscle. So it needs to respond like a trampoline to your movements and the level of skill required for those movements, right? So you're jumping on a trampoline, you're going to need your pelvic floor to be able to relax when you're in the air and contract when you're bouncing, for example, to support everything. So if you are, let's say, contracting and relaxing like a bicep curl, that's great, right? Because you need the length, tension, and the muscle to be able to facilitate strength and support and blah, 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 right? So let's say you're here because you have to pee all the time. It's really annoying. It's freaking you out. So you've got a fear, you're fearful, but you've also had a couple kids. You might have a little cystocele that's putting a little pressure on things. And you're always guarding and bracing because you're like, hell, I have to pee all the time, but I can't because I have to do this. And I'm sitting with a patient and I can't pee right now. But then it's like always on your brain. So it's amping up your nervous system as well, right?
And it's so annoying, as Natalie says.
Yeah. And so you're here all the time. So then you go to, I'm just going to give an example. You go to run and the body can't necessarily support. Maybe halfway through your run, you start to leak because now you're like, you've only got this much.
Oh, I see. That full flexible response to the situation.
Yeah. Because if I was like, I came to you and I'm like, okay, I want to strengthen my bicep curls, Patty. can get like, how's this going to work? Right? You're not
Yeah. You need to relax fully and contract fully. Got it. So high tone is when you're to contract all the time. Got it.
Yeah. But the contractility of the muscle varies because it can be neurological, as you know. It can be for many reasons. It can be fear-based. It can be emotionally based. Like there's so many things that play into it. So you can't just structure it around like, oh, my muscle's tight, it needs to be released. Well, you could go in and try to release somebody's pelvic floor intravaginally and it's not working, right? Because a lot of the time where I end up going is not to the pelvic floor specifically. So you see what I'm saying? So there's a lot of things that play into, you know, getting the pelvic floor to down train so you can re-up train the whole system to support what your goals are.
So it's like the end goal is the same for every woman, but the journey to get there will be so individual. Sometimes it's like loosen this muscle that's too tight and then strengthen this muscle back up again. And then the neuro, and you mentioned the biofeedback when you're using ultrasound. And what I think about when I hear that, and some people may not understand that, but I'm a physical medicine rehab specialist. I work at GF Strong. And so we like, you know, our work is very like intertwined. We actually share patients. And so is that something that you do where you put the ultrasound on so you can see that the deep layers of the muscles and see if they're too contracted or not relaxing enough. And then the person themselves can see it. And when you're like, see how it's too contracted, try to consciously relax that, and they can actually visualize that. Is that what you do?
Lies on the bed, right?
Yeah.
Right. And then my ultrasound machine is this. And it projects to my phone.
Oh, okay.
And so I ultrasound, so you're getting that visual image of pelvic floor. Now, it's not perfect. You can't assume anything from it. But because I've been working with the ultrasound and the pelvic floor internal exams for like 9 years, I have been able to do some comparative analysis while I'm doing examination and kind of, you know, reflect on, okay, what did I see in the ultrasound and what do I see now? What did the pelvic floor exam show? And are those connected? Like, is it, you know, am I seeing the same thing? And a lot of the time I do now, right? After many years.
Pattern recognition.
And so then this is where it goes. And then we do another sagittal view, which will show us more. And then I also do transperineal ultrasound. So that way. So transperineal ultrasound is phenomenal because for women who haven't had intercourse yet after baby or have painful conditions, it allows the opportunity to be able to have the assessment externally first and get a good idea of what might be going on before going intravaginally and just, you know, developing that sort of, they get to see as well. So you reduce a lot of the, you know, the external things that may be impacting it because they're like, oh, wow, okay, I can see that and it's not painful, because realistically, you should never have pain greater than a 3 on 10 with a pelvic floor examination, FYI.
Right.
So, you know, and there's a lot of practices that do need to happen to create a safe space and autonomy with pelvic floor exams too, right? So that is important. And that's why the ultrasound is very useful in that sense as well. And of course I can use it with kids because you can't do internal exams in kids and teens. So
right.
Well. Yeah. And so it's something that allows the individual to get a picture in their mind of what may be going on, so that then when you do the vaginal exam, this is just my clinical experience, there's more of a understanding and opportunity for them to go, okay, this makes sense, right? So
it's a mind-body connection, and Natalie was saying she notices it's worse when she's anxious, so that makes sense. And whatever tools we have at our disposal that we can highlight and illuminate and connect and strengthen the connection between mind body, and that sounds like a really lovely tool where you actually get to see, and then you start to become more internally intuitive.
Yes. Yeah.
Right, which I think is what you're trying to develop with people too. Is like to does that make sense?
Because I mean, I don't believe in people coming to me forever. Now, I have patients I've been seeing for 12, 15 years, but they go and do their thing, and maybe they fall off their mountain bike and they come back, or they have another baby and they come back. And so it's more so I want to be this sort of like like coach sort of consultants in their life, and instead of like, you know, oh, I need to go to you to fix this. Like I can't, let's be honest, I can't cure anything, right? It's a matter of giving the tools and the education and the support to understand and manage moving forward, right? So I think that's where I have definitely changed my practice in the last probably 7, 8 years, in going, okay, like this is how I want to be a facilitator and a support and a coach, like I said, as opposed to, you know, this is what we can fix, because that's kind of setting up false.
Well, and you could also limit it. Like maybe you can achieve more, right? And it's like, and when you have this like set expectation, you start to go down this protocol, and you don't open yourself up to the flexibility of what that person can show up with day to day, right?
Which brings us back to full circle what you said. So that end goal is going to be different for every woman. So I have some women that want to be able to run, but I have some women who want to be able to do yoga, but they're queefing while they're doing yoga, and they don't like, well, obviously they're like, I'm not doing that. And then I have some women who are like, I don't want to exercise. I just want to be able to run after my kids. And, you know, or I have a, you know, professional motocross racer who doesn't want to have testicular pain while he's, you know, riding. So every goal, each person, and that's a huge thing I do with people, is what is your goal? What would you like to get from this? And it can be anything. I want to have sex again. I want to reach an orgasm because I've never had one. And so it can be variable depending on the person, and they all have different histories as well. So you can't really sort of slap a recipe on any of it either.
No.
Right?
Yeah, totally. And that's a beautiful thing, actually, because I get really worried when people have like very rigid protocols. Yeah, exactly, right. Which for some people might be the thing, as you say, but it's not like the cure all and be all. And if you have like some specific issues, it could make it worse.
Absolutely.
Yeah. And I have a comment and then kind of like a starting to wrap up thing, because I want to make sure that, because, okay, for my first comment is that it can, like, and you mentioned this before, and I want to highlight it again, is that it is very common to have a structural problem, right? Combined with like a neurological, like, and you could think of anxiety affecting as neurological, right? Like these neural networks are starting to down feed information into it, and it's causing this, like, you know, issues with the muscle tone. You can have emotional, which is own chemistry of emotions, and then you can have hormonal, and a really good example, I'll use myself as an example. I noticed that as my structural integrity has improved over time, I don't get any leakage or any urgency, except for some very, and it's getting better, but I noticed that it's the residual last little bit, just about before I'm about to menstruate, in my luteal phase. And which is very, very interesting, right? Because you get a lot of hormonal shifts happening there. And as my hormones, as I've healed my hormones, that has resolved.
Yes.
You know, but I had to do the whole thing. So I find that the human body is so fascinating, because when you're working at something and you're focusing on structural, you do everything you can, and then you see what's left over, and then the what's left over bit, right? Then you have to dig into that a little bit, and I love that you have a recognition of that. When clinicians don't have the humility, as you say, to say, I'm not going to fix this for you, I'm going to be your coach and your guide and your facilitator, that allows you to be open to being part of a holistic team.
And that's my big belief. You have to, it's not all one-sided, right? And it's very much, and also you may need a pelvic health physio that you just don't jive with. So that's okay too, and that's normal. Go find someone that you jive with, right? Like that's the big thing too. So
so this was actually, that's a perfect lead in. How does one, okay, I imagine you're gonna what we'll do is we'll post your, like, it's Bow Dynamics, we put it up in the event, your thing, and I think a lot of women are going to be calling you. It sounds like quite a bit of what you do needs to be done in person, especially when it comes to the pelvic floor, like the, but or like how does that...
like yes, in a certain extent, but also, like I said, a lot of it is education as well, and just and so a huge part of sometimes what I end up doing is people will be like up north or, you know, back east or wherever, and they just want to have that first conversation with me because they've identified with me, right? And then they want to, then I can go, okay, you know what? Because I know everybody that's in pelvic health. So then I can go, look, I think you might be best suited to see this person and they're in your area or whatever, right? Like there's lots of phenomenal pelvic health physios out there, and you know, there's more than enough people that need support. So I think just, you know, I have people in certain areas that I refer to all the time. So Vancouver, so they don't have to drive all the way out here. I'm not that far, but you know, but for some people that can be a big roadblock. So, you know, that's why that initial conversation can be really great through telehealth, for example, right?
So, and where are you physically located? Is it White Rock or is it
I'm
I
in
saw Delta in
Yeah,
Tsawwassen. Okay.
so it's like Delta, South Delta.
I see. Okay. Okay.
Just off the highway. So a lot of people, like I do see a lot of people from all over, but it is an individual, obviously,
Yeah.
thing.
And let's say, so that it sounds like the options are to connect if you're from far away, if you're listening to this and you're not in like near Tsawwassen, which is south of Vancouver, and one option is to do a telehealth consultation with Tamara, and like she can get a sense for where you're at and guide you with who you could connect with in your area. Are there any tips you would give someone who's looking for like a pelvic floor physio specialist, like things that you would look out for, like would you say it's very, very important to have at least, let's say, 5 years of ultrasound experience?
Well, not everybody
You know what I
has
mean?
access to an ultrasound, so that's the
Yeah.
other thing. So it
Yeah.
depends on what you're going for. Like, the ultrasound is so useful, but like I said, a lot of people don't have access to it. So I would say that, you know, you want to be with a clinic or a person that obviously is well trained, has their education and extra courses and so on and so forth in pelvic health. And then, you know, try your first visit with them. And if you're not happy with, you know, what that entails, then be honest and move on, right? And find someone else or ask them, hey, look, you know, I really feel like I need to be seeing someone closer to me, or someone that's, you know, has maybe a bit more experience, or how, I don't know, right? But I always tell patients, like, be open to having that conversation, because you want to meet your goals. And if your goals aren't being met and you're not being supported with autonomy, and you know, like it's your appointment, then you need to be moving on, right? So yeah.
Yeah.
Mm-hmm.
And then is there anything else you want to add? I was going to ask you a question, like what are like 3 things you wish you knew before you went down this route, like that you wish you had known 10 years ago about the pelvic floor, like just unless there's something else you want to add in before we wrap up.
I think one of the big things that I've learned over time, and which has hugely shifted my practice in many, many ways, is it's not all about the pelvic floor. And usually the pelvic floor is the victim. And so you don't go after the victim. You have to find the source. And there can be multiple sources. And it's important that people, that, you know, the community understands that, you know, that is a huge part of how practice then shifts from, you know, I guess, shifts from where we're at to more preventative based, right? So let's educate women, like let's get into the schools and start talking about this with kids. And, you know, you can make it fun. And like I went and taught my son's kindergarten class about their breathing and pelvic floor.
No
right?
way, really? That's amazing.
Yeah, and I didn't use any, you know, language that was inappropriate, but I mean, kids need to know that it's a penis and a vagina, and that's normal language, right? We know that in literature that is so important. So if you can start to have that conversation, then I think that will shift the pendulum to being, you know, crisis-based management as opposed and to more preventative-based management, right?
Right.
That's the big thing that I think I've kind of wish that I knew many, many moons ago, but but now I've come into that in the last probably 6 years for sure.
Wow, that's amazing. I mean, I've learned so much in this last little bit, and I always love, it's not possible for one person to know everything, right? Like I'm a physical medicine and rehab specialist, and you know, we're taught all of this stuff, like I know, but it's not something I see every day. And I certainly have not used ultrasound to evaluate. I use ultrasound for other things, but not for the pelvic floor. So there's a value in searching for people who have, like yourself, who have this like expanded, like you went into it and expanded into it, and you also have what I perceive to be like a deep compassion, and you have like a purpose and like to help women. And so this is something that really animates you and drives you, and I can tell that woman would really get the benefit of your energy with that. So
yeah, that's the goal, right?
yeah, totally. So yeah, I want to make sure I know you have a patient coming up. I want to make sure you have time for them. Is there anything else that you wanted to add before we go? There's no other questions I can see here from the chat.
Yeah, if anybody needs to or wants to get in touch, just email me. That's the best way. And like usually I can shoot them a quick email back if they're, you know, across the country or somewhere. They just have a question of who should I see. I will be more than happy to.
Great. What's your email, Tamara?
bodynamicspt@gmail.com. So I'll spell it quickly. bodynamicspt@gmail.com.
Okay, I'm just putting it into the comments now. Perfect. Awesome. Well, thank you. You know, I know you're super busy, so I really, really, Tamara, appreciate you taking the time. It's so wonderful, and it's wonderful to see you too. And what we'll do is whenever you have some spare time, we'll bring you back on similar kind of time to talk about more, because I know we have like so many awesome things to learn from you. I'm so grateful for your wisdom. Thank you.
Thank you.
Okay, have a great day. Enjoy that sunshine.
Thanks.
Okay, bye.